the second part of this goes a lot quicker. So complications, we talked about the respiratory, we talked about constipation. What's orthostatic hypotension? Yeah, from change position, from lying to sitting, sitting to standing, that blood pressure drops. So orthostatic hypotension is very common with people that are on narcotics. So if you have your patient that you're giving narcotics to, they will be a fall risk because you don't want them to get up on their own when they have that on board. Urinary retention can also, again, it slows everything down. Constipation, urinary retention. So if you have men that have like enlarged prostates already, you can actually cause them to not be able to pee. So watch that. Sedation, cough suppressant. The one thing that we do not want to do is give morphine to patients that come in with suspected gallbladder problems. Biliary colic, it can actually make it worse. And so if somebody comes in with abdominal pain and they're like, oh, I've got pain in my right upper quadrant, don't give them morphine because until we rule that out, because it can make that worse. So it would be contraindicated in biliary colic or gallbladder issues. Nausea and vomiting. We'll do a lot with, you guys will do a lot with pupils when you get into neuro assessment with Michelle in health assessment. Your pupils are great. They do amazing things. They're one of the coolest things that you can do, and you'll do pupillary assessments on people, and different medications can either cause pupils to constrict down or dilate. And different, like whether it's PCP or heroin or depending on what it is, your pupils will do crazy things. Head injuries will make your pupils do crazy, crazy things. So pupillary changes are a clinical red flag in nursing because it can actually indicate something more is going on with your patient. I talked about don't give morphine with biliary patients or premature infants. We don't give a whole lot of narcotics in premature infants anyway. It's most are pregnancy C, we usually don't give them. Here's the thing, we can and do give narcotics during labor, because turns out labor hurts a little bit. And if you didn't know that, Jeremy, it does. And it doesn't hurt you, it hurts your wife. Although you would think sometimes.
I mean, you'll get hurt in the process.
You don't get a narcotic for that. But it can cause the baby to come out sleepy. So we got to be careful about how much narcotic that we give. And later on in the slide, we'll talk about Nubane and Stadol, which are better options for pregnancy narcotic if we're just going to give 1 or 2 doses of it, because it doesn't have the respiratory depressive effect on the newborn that narcotics do. But people that get epidurals, you're going to give them a narcotic in that epidural. And so it can cause the infant to come out kind of sleepy and lethargic. And so then I need to watch both mom and baby. Okay, going on. I talked about this, that they interact with alcohol or benzos or barbiturates too. Your barbiturate medications are more your psychotic medications. They increase the sedation. Anticholinergic drugs, things that will dry you up. And atropine, scopolamine patches. Scopolamine patches are the thing they put behind your ear that helps with dry secretions. It looks great for motion sickness, like before you go on a cruise. They give them before OR for patients so they don't get post-op nausea and vomiting too. Tricyclic antidepressants. I've said this over and over and over again. Don't give alcohol with anything, don't give Coumadin with anything, and don't give an MAOI inhibitor with anything, because they just don't mix well with others. So those are your big 3, and no grapefruit juice with anything either. It seems to be those are like your big ones that. Why would you want to use this in caution with somebody that's on a blood pressure medication? So I go in, I give my patient their blood pressure medication in the morning, and then I hit them with a narcotic. Yes, it can cause further hypotension. So I would want to make sure that I'm monitoring that blood pressure and not letting them get up on their own. Because with their blood pressure medication, they may be 120 over 80, but I add that narcotic and now they're 90 over 60. Does that make sense to everybody? Assess pain and vital signs before you administer. Before you give a patient a narcotic, know what those vital signs are. If you take a blood pressure and the blood pressure is 90, you don't do it. Don't do it. Because you can cause a problem. If you take that respiratory rate and it's 10, don't hit them with a narcotic on top of it. Okay? Know what that is. Know what that pain is. If they're telling you their pain is an 8 and you give a narcotic, you need to know what it is beforehand so you can assess and evaluate how effective you were at the end. If you don't ever ask them the question before, how do you know that you're effective after? Does your pain get better? Yes or no? That's not. You need to quantify that. So get that pain scale. Double check your dose. Make sure that you're wasting with somebody else. Administer it slowly. Naloxone and Narcan is the antidote. Okay. Okay. These are an agonist, antagonist. Butyrophenol, Stadol, nalbuphine, is Nubane. Buprenorphine is Sublocade. Okay, Nubane and Stadol you'll see pretty in OB. If you guys, anybody here want to be labor delivery, you'll see Nubane and Stadol for sure in OB. Taliesin and Talwin, we typically see these for patients that have chronic pain conditions. And so you may see that class of medications given for them. I do not expect you to know doses of every single medication. I do expect you to know the limit for like Tylenol, it's 4,000 milligrams. I will give, if I'm asking you to calculate somebody's, I will give you the dose that's in the medication. Like I will say, Norco 5 to 325 milligrams. I will give you that. But do know that 4,000 for Tylenol is the limit. That's too much. No way would you be able to memorize all of that. Or you can. If you can, kudos to you. Write them all down and I'll give you extra credit if you get them right.
What about the max doses you were talking about?
Like 4,000 for Tylenol. Yeah.
That's the big
Yeah,
one?
that's the big one. And Toradol, no more than 5 days. Okay. These are less potential for abuse. They don't experience the euphoria and less respiratory depressive effects. So we like to use these for labor and delivery because they don't have the effect on the baby. And so we can give them for the treatment of opioid abuse because they don't have that euphoric effect. And so we can help to wean people off of narcotics using buprenorphine, is a common medication that you'll see people on if they're weaning them off narcotics. Abstinence syndrome. Because these don't have the euphoric effect, if we take somebody off a narcotic and we put them on this, they can have like severe withdrawal symptoms acutely. Still some of the same effects that you will have with narcotics though, respiratory depression, just not as severe side effects. Still don't want to give them with CNS depressants or sedatives, and you don't want to give them concurrently with opioids because they can make those effects worse. Still want to do baseline vitals. Naloxone is still your reversal agent. Change position slowly for that orthostatic hypotension. So just a different class of medications that are a little less, symptoms, side effects are still very, very similar, just less severe, okay? Opioid antagonists, these are your reversal agents. These are your reversal agents. naloxone, naltrexone, methyl naltrexone, avimapam, all what we give to reverse drugs. And if you look on the next, it's going to show you what we give them for. Opioid and alcohol dependence, opioid overdose, opioid-induced constipation. That is a medical diagnosis. We know that it can cause constipation, so now there's actually a medical diagnosis called opioid-induced constipation. And Relistor is a medication we can put patients on to treat that. Post-op bowel resection or an opioid ileus. So if you give somebody a general anesthetic and then you operate on their bowel, you're gonna paralyze the bowel, because you don't want the bowel moving when you're in there operating on it. If I give somebody general anesthesia, it paralyzes the bowel, it paralyzes everything, not just it's gonna shut everything down, and you want that, because you don't want somebody vomiting during surgery, you don't want them defecating during surgery, you want that paralyzed. And then if I operate on their bowel, that can make that complicate that even more, because it shocks that organ as I operate on it. And so it takes it a while for it to start working again. And so they're at high risk for developing what we call an ileus, where you have the stoppage of peristalsis. There's a difference between a bowel obstruction, meaning there's something completely obstructing the bowel, like a tumor, impaction, something, lots of different things, versus an ileus, which means I just halted peristalsis. Nothing's moving through. If I don't fix an ileus, it will lead to an obstruction. So if I have a post-op bowel obstruct or ileus, I can give this medication that actually stimulates the peristalsis of the bowel. Start up again.
My son has to have that
After
after every surgery.
every single surgery.
He has a slow bowel anyways, and I've tried, that's a whole other story, but
Yeah.
he, after every surgery, he has to have that medication.
Know what they're for. Know what they're for. Again, remember, if I give a narcotic reversal agent, I'm going to reverse the effects of what that narcotic was supposed to be doing. Like I give somebody pain medication for a reason, but if I give them naloxone, I'm going to reverse that. But it has a shorter half-life than the actual narcotic does, so be careful. Be careful, you may have to give it more than one time. Especially in people that have overdose, we now have medics and police officers that will carry Narcan on their trucks and in their cars, and you can inhale it. It can be given intranasally. And one of the biggest things that happens is they give it and then they walk away thinking that that's okay, that they gave it and it reversed it, but then that wears off and the narcotic comes back in and they actually can be severely respiratory depressed again. So we gotta make sure we're keeping an eye on that patient. Abstinence syndrome, severe withdrawal symptoms. Do you guys know what tachycardia and tachypnea mean? Fast heart rate, fast breathing as I start to come off that medication. These are contraindicated in patients with opioid dependency. There is a difference between opioid dependency and opioid overdose. If I have somebody that has an overdose, it's a life-saving measure. If I overdose on my opioid, then please give me Narcan because you're saving my life. If I'm dependent on my opioid to get through my day, or I'm chemically dependent on it because I've abused it, if I reverse that, they're gonna go into withdrawal immediately. Okay? So we wouldn't wanna give them a reversal agent, we would give them a medication that would help them, methadone, bupropion, to get them off of it long term, but we don't want to immediately just halt it. The two people that you cannot give naltrexone to are mothers that are breastfeeding or patients with liver disease. Okay, here's the thing. If you guys are nurses on the floor, you'll know this. You'll know that they have liver disease because it's going to be in their history and physical. You'll know that they're a lactating mother because they've probably shared that with you. If you're out in the public, if you're a police officer or a medic and you drive up on the scene and somebody's down and unconscious, they're going to give the medication because they don't know that unless somebody's there to tell them that. But again, if it is a life-saving measure, that trumps the contraindications. Does that make sense? I wouldn't hold off giving a reversal agent to somebody that's overdosed and is dying because they're a lactating mother. I mean, it's better to save their life and maybe not be able to breastfeed than it is, or save their life and damage their liver than to let them die. Okay? So these are guidelines, but they aren't hard, fast. You know, that's where your clinical judgment comes in. You don't just say, well, sorry, you're breastfeeding. You don't get to live today. That's not how that works. It sounds dumb when I say it that way, but you guys will come to a test and there'll be a question and somebody will say, well, I wouldn't give it because they're a lactating mother. If they're dead, yes, you would. Okay? Observe for withdrawal symptoms. Be prepared to administer alternate forms of pain control that are non-narcotic. So your biggest class of medications that you can give are your NSAIDs. Okay, I'm gonna tell you right now, ibuprofen is not going to be sufficient to control pain if somebody's used to taking opioids. Okay, so they're gonna hurt. The half-life of opioid may exceed the half-life of the reversal agent, the opioid antagonist. You may need to repeat it. Keep monitoring their respiratory rate. Keep monitoring for signs of sedation. You can sometimes titrate to relieve the symptoms without reversing. You can, if you catch it early enough, and you can see it coming, you can give lower doses, smaller amounts, more frequently to try to reduce the sedation without withdrawal, with holding it completely or reversing it completely. Most times when we're giving these, you all of a sudden you are out taking care of your patients and you hear that pulse oximetry monitor go off and ding and ring at you, and you go in and your patient's not breathing and their O2 sats are starting to drop. You don't have time to titrate it then. You give it. Different things we can use for pain medication. I'm going to go through these very, very quickly. Here's the thing. We will hit these in other units. No medications that you can give for reversal agents. No. No medications that you can give as adjunctive medications. I'm not going to ask you about the side effects and complications here because we're going to cover tricyclic antidepressants later, and I'll hit you with that there. But know why.
Oh, okay. I was just gonna ask, like, the study guide, because you have this listed.
Yeah.
Just to know.
I want you to know that you can give tricyclic antidepressants, anticonvulsants, CNS. We are going to go through all of these medications in different units.
So just know what they are.
Know what they are, right? Well, except for NSAIDs, you do need to know that for this test,
Yes.
please. All right? But I'm not going to go, what is your complications of an anticonvulsant? What are your interactions? Because I'm going to, when we talk about neurodisorders, we'll hit that there. And so there's no need for you to do it here. Or we would just start now and do it all and test you at the very end, which is nobody wants to do that. Nobody would want to do, you're like, no, it's too much. It's too much. Tricyclic antidepressants are great, especially with people that have chronic conditions or chronic pain. If I am in chronic pain, it can be very depressive. I can become, I mean, it's a side effect. Depression can lead to chronic pain can lead to depression. It's kind of one of those things, what came first, the chicken or the egg? People that are diagnosed with major depressive disorder hurt. They will have physical symptoms of pain, okay? People that have long-term chronic pain issues will be depressed because they live in a constant state of pain. Tricyclic antidepressants, Elavil, amitriptyline, those types of medications help to help treat that depression, but also they help make those narcotics kind of work better. They hit different receptors that help that work. You can sometimes give lower doses of narcotics because you can put them on some of these adjunctive medications that are gonna help that work. I'm gonna hit that pain at more than one area of that pain process, so I can make those drugs work better by adding something supplemental. Anticonvulsants, these medications are huge with like peripheral neuropathy, gabapentin, carbamazepine, Tegretol. That peripheral neuropathy, when we have that interrupted pain pathway, these work great with that. And sometimes we can put them on these medications and they don't have to get narcotics at all. Restless leg syndrome, peripheral neuropathy, what's the, not Bell's palsy, nope. Trigeminal neuralgia. I'm like the three nerves, the trigeminal that has that neuropathy pain where they get sharp shooting pain. That Tegretol, carbamazepine is one that they use for that. CNS stimulants can help sometimes. Antihistamines. Glucocorticoids, I talked a little bit about glucocorticoids earlier. They help decrease the inflammation. So just know that you have medications that you'll see in conjunction. And I've had nurses do this. Well, why are they on a tricyclic antidepressant when they don't have a diagnosis of depression? It might be for pain control. It may not be for the use of an antidepressant. And a lot of times when they're on it for pain control, the dosages may be smaller, maybe less. Or you'll see people that are on some antidepressant medication sometimes for sleep disorders, and they aren't necessarily on it for the psychotic or the antipsychotic effect. They're on it for other reasons. So don't assume that somebody has a psych diagnosis just because they're on some of these medications, I guess is what. Don't assume somebody has a seizure disorder if they're on Neuron. That doesn't necessarily, it may be getting it for a different reason. And so this will be huge for you guys when you guys start to do your care plans, and you'll write your medications out and why your patient is on it. Because you all want to just go, oh, they're on it for seizures, but your patient doesn't have a seizure diagnosis. So know why your patient is taking a medication. Sometimes we give medications for other reasons than what the actual class of the medication is or why it is. Or you'll say, my male patient is going to have dysmenorrhea. No, they're not. They don't have that. They don't have periods, so they can't have abnormal or absent periods. So please don't say that. Yeah. Women can't get gynecomastia, male breast both, because we're supposed to get breasts. We have breasts. So be very careful with that, because you guys get lost in the weeds as you're starting to write that out. So this is kind of why you use them. And I wanted you to see that there's different reasons why you would put somebody on the different ones. Bisphosphonates is really, people that have bone cancer, we put people on bisphosphonates. You guys haven't got to electrolytes and patho yet, have you? It's toward the end, right? I think it is. Calcium and phosphorus move in the same direction. If my calcium rises, my phosphorus rises. If I give a medication that's going to help lower my phosphorus, it's going to lower my calcium. So that's why that can treat hypercalcemia. Hypercalcemia is high calcium in your blood. Calcium and magnesium work opposite of each other, okay? So there's things that you'll learn, but that's why bisphosphonates work. Okay, these next few slides, you're going to see this information again. So I'm not going to spend a lot of time here. Actually, I'm not going to spend any time here. I got really happy when I did all these slides, and then after the fact, I'm like, well, that's really dumb. And it was a big waste of my time. So we will talk about these medications. We'll talk about tricyclic antidepressants when we talk about neuro disorders. I'm going to flip forward here. There's a lot of information. Please just bear with me. You cannot study this. As I flip forward, just don't study. Okay? Migraine medications. These you do need to know. NSAIDs again, so that's a repeat. You're not studying it a second time, just study NSAIDs one time. But triptans and ergot alkaloids are big for headaches and anti-inflammatory medications as well. Migraine medications, there's migraine medications that are preventive, meaning people take them either a daily or they take them when they, if I say aura, do you guys know what an aura is? Does anybody know what an aura is? What's an aura?
Flashing lights.
Okay, you'll see people, migraines and seizures are two disorders are big with auras. People sometimes will have a warning that it's coming. Some people may have flashing lights. I've seen people, like, they'll hear noises or they'll just have a feeling, and then they know that either they're gonna get a migraine or they're gonna have a seizure. And so it's kind of a warning of something to come. And they can then, during that time, take that medication to prevent it for migraines. Seizure disorder, the aura is more, they can get themselves to a safe position, because it's better to be laying on the floor when you have a seizure than it is to be standing, okay? You can't really, there's no like abortive medication for seizures that you would give somebody that they could take on their own. We have the medications that we can give IV in the hospital setting, but not just orally. They'll be on seizure medication all the time. When you're giving, the theory behind a migraine is that you have severe vasodilation of the blood vessels in your brain, of the vascular system in your brain. And so because they dilate, that's people say that thumping, no feeling. Does anybody in here get migraines? What does it feel like when you get a migraine? Olivia.
Oh, it's like that pounding.
Pounding.
Yeah.
Like you almost think you can feel your heartbeat in your head.
Yeah.
And it's that severe vasodilation that thumping, pounding pain. And so sometimes you'll even have patients that will be on blood pressure medication, beta blockers, because it lowers that pressure that's in their brain. So you're either trying to lower the pressure that's in those vessels, or you're trying to cause those vessels to constrict down. That's why people say caffeine can help with migraines, because it causes vasoconstriction. So Excedrin migraine has Tylenol in it, and it has aspirin in it, and it has caffeine in it. And so that's why that is kind of beneficial for people that have migraine headaches. Anybody else have any?
Yeah, for me, it just starts feeling tight, and I start to lose vision and whatever.
That's your aura.
Yeah.
Yeah.
Mine is, I can always tell because the left, right side of my neck gets super tight.
Mhm.
Like I wanna crack it, but it just won't crack.
Yeah.
There've been times where I've had like, looks like a Z, and both eyes just shaking. It's like green and red. And then I know I'm gonna throw up.
Yeah, nausea and vomiting, big side effect of migraines. A lot of people will say until they vomit, they can't feel better. They've got to vomit. And you want photosensitivity, very sensitive to sound, light. You just want to crawl into bed. But even like those, there's a new thing that's on the market right now, and it's like a hat, but it's a cold compress. Has anybody tried that?
No, I want to.
It fits over your head and over your eyes, and it's like a sock cap, but it's a cold compress. And it's to when things are cold, it vasoconstricts down. I'd be curious to see if somebody has one, if it really works. Go get one. Let's do it. Experiment. Okay. Aspirin-like medications. Here's your aspirin, acetaminophen, and your NSAIDs. Serotonin receptor agonist. This is your triptan, sumatriptan. Sumatriptan is kind of the most common one that you'll see, but there's other ones that are out there. Ergot alkaloids, ergotamine, dihydroergotamine, ergotamine. Okay. Beta blockers, propranolol. This is a blood pressure medication, so be careful. Because if I'm giving a patient a blood pressure medication, and some people will be diagnosed with propranolol, but it's not for high blood pressure, it's for migraines. And it will be a lower dose than what it would be if I'm giving it for blood pressure. But I need to probably periodically check their blood pressure to make sure that I'm not causing it to be too low. Anticonvulsants and tricyclic antidepressants as well. They all work in different ways to help that migraine pain. We used to give narcotics for migraines, and we just don't see that as much anymore. Even when people come into the ER, they usually give a Benadryl like Toradol, an NSAID, and something for nausea and vomiting. There's usually a combination that they'll pull up and try first before they'll give the patient a narcotic. And then estrogens also, because in females, migraines are very closely associated with our menstrual cycle or menopause. And so sometimes we can put patients on low dose birth control pills, or women as they go through menopause on low dose hormone therapy, and that can help with migraine headaches too. Okay. Aspirin-like drugs we've talked about already, and NSAIDs. And then we'll talk about some of these other ones again, but, because you can give, triptans are most commonly given for migraine headaches. The biggest complication for triptans is they feel like they're having a heart attack, which is never good. I don't want to get rid of my migraine and feel like I'm having an MI. Or they'll get, because they get coronary artery, so the arteries that supply your heart, supply blood to your heart, will start to spasm. So you can get spasms in your brain from taking it, but you can also get spasms around your heart. And so they'll feel like they're having an MI. That's the big one with triptans. Guess what? You have to avoid MAOIs with everything. That's always going to be the answer. If it's a select all that apply, it's probably warfarin, MAOI, and grapefruit juice. Like, don't do it. Serotonin syndrome. You guys will talk about this. We'll talk about this again when we talk about mental health medications or neural medications, and you'll talk about it in mental health next semester if you take it next semester. People that get too much serotonin in their bloodstream, so you have a serotonin receptor blocker, so it's just too much in your system, in your blood system. It's not getting to the next receptor. You're blocking that from happening, and so they get a buildup of serotonin in their blood, and it can cause this constellation of symptoms along with that. Big ones for ergot alkaloids, it's pregnancy X. Don't give it, it will cause abortion, fetal harm and abortion. They cannot take them. So if you have somebody that's on an ergot alkaloid medication for migraines, they cannot get pregnant. Just like tetracycline, you shouldn't get pregnant, you shouldn't get pregnant. You're looking at me. Were you on an ergot?
Oh, no, I'm just thinking, so if she does get pregnant,
They would
she
have to
has
switch.
stop this
Mhm.
medication.
They'd have to switch the medication. Yep. And you don't want to take these on a long-term basis, short-term basis. Those are the big ones. Look, grapefruit juice. Oh, I flipped way forward backwards. Don't take it with grapefruit juice. I know you guys don't think I'm funny when I say it, but it's so common. Beta blockers, bradycardia and hypotension. That's your big one. First degree heart block. If you have somebody that's in first degree heart block, you do not want them on a beta blocker for migraines or for blood pressure, because it can lead to a worsening heart block. Meaning that, when you guys were in anatomy, did you talk about the electrical pathway of the heart? You guys love it when I refer back to anatomy, right? Yes. So you have your sinoatrial node, it fires, it sends the electrical impulse to your AV node, and then down through your ventricles,
She
right?
did it last week and a half,
Oh, good. So then, if you have a block, did you talk about blocks at all? Did you talk about blocks? Okay. So if you have